Good morning. Thank you for coming. Thank you for being forced students. I'm sure. I know how we work. So Randy had asked me to say a few words about my background, which he pretty much just said, and you've been reading for like 10 minutes now, so I won't bore you with that. And then a few words about my teaching experience. Most of my teaching has been at medical schools, and that has been in the classroom, and then I'm a clinical ethicist, so I consult in hospitals and I teach, like in the third-year clerkships. And I would consult be part of the patient care team in anything from A to Z, OBGYN, surgery, anything you could imagine. So I'm very clinically oriented. And those are the areas I teach: ethics, cultural competency, community service learning, and of course global health. Levels would be everything from undergraduate, liberal artsy type, but that was when I was at Georgetown, so I really have done mostly medical education since. And then all the different levels of medical education, including residents and senior attendings. So, as a result, I'm uniquely empirically grounded. Now that comes both from my anthro background, my social science background, but very much so in the clinics. It wouldn't be tolerated if I were nattering on about vague abstractions from philosophy. They wouldn't serve that audience, and so I tend to think and act that way and teach that way. And I like real cases, not paper cases. So most of the time when I'm teaching, I use cases from my clinical ethics consults and difficult consults I've had to do. So the students like it much better. It's much more effective for them. It speaks to them. Another unique thing is that from having worked at University of Newcastle in Australia, they're world leaders in medical education, and so they just naturally publish all their teaching innovations and their assessment innovations. And if you do assessment in a certain way, you want assessment to drive learning. And so I've just, for the rest of my career, I also just write up my curricular innovations for publication. And it's a nice way to get higher level peer review, but it's also a nice way to share what you've learned and the kinds of strategies. All my work is very engaged. I'm an ethicist, social justice-y type, so that just comes naturally. And then I mix my methods for the type of learner I have, the type of goal I'm trying to achieve. Might use peer learning in some cases and not others, etc. So that's just a brief little thing, and now I can speak on my topic. And I don't want anyone to get scared when I'm going to talk about the dark sides of altruism or sound really judgy, ethics judgy. I have a passion for global health, like I'm sure everyone in this room, and that's what I'm driven by. And this is encouraging positive self-reflection and proactive self-reflection before we go off and do things we could prevent harms and damages we might do in our work with our passion. So I want to look at things like mixed motives, multiplying inequities, cultural incompetencies, and some general incompetency, possible complicity in endemic corruption, and inadequate consultation with our partners in lower and mid-resource countries. So, starting with the context of global health, this is very known to all of you here, likely, so I don't want to preach to the converted, but obviously inequities, sociocultural determinants, and preventable deaths and remediable suffering. So that's what's driving all of us, of course. And I always conceive, coming from South Florida, we have the largest amount of Caribbean expats in the whole nation. Florida, New York is second to us, but you can do global health in South Florida. You don't need to go to the Caribbean or someplace else. So, and I know Duke thinks of it this way too, which I really like, because it's the local and global side of the coin. So, those groups. So starting with mixed motives at the international level, if we think about the strategic interests of all the actors who are acting in global health, and if any of you have been to CUGH, and I know some of you have presented there and been there, and if anyone's read Joanna Crane, the medical anthropologist's critiques and ethnography of Consortium of Universities for Global Health, you'll see a lot of these things operating, and social, political, and economic philosophies and agendas of the various people contributing to and driving global health initiatives. And so it's easy to lose sight of that, I think, unless you are focused on it, as she was in ethnography. And also the funding, of course, is going to be driven by the strategic interests of high-income governments, transnational corporations, philanthropic institutions, and international financial institutions like the World Bank and IMF. And the World Bank, of course, you know, you'll look at a lot of countries where they've gone in and privatized the healthcare systems. And then you see a lot of problems for that, for the people in the society, and increasing inequities, and so there are a lot of issues like that at work. And then just the term itself, evolving from, you know, as we know, tropical medicine, tropical health and hygiene, to international health, to global health. And part of this was driven by WHO wanting to essentially brand themselves, like Duke wants to brand themselves, like I wanted to brand my medical school where I work now. And, you know, it was explicitly to reclaim power and visibility that it had lost to the World Bank. So that's, again, it's altruism, yes, but there are a lot of other agendas underlying that. And then another mixed motive at the national level is that global health is conceived simultaneously as national security issue, fear and crisis about infectious diseases crossing borders, infection threats, you know, to us versus others, whoever you are, talking from whichever end. And then, of course, a genuine compassion and concern for the poor and global inequalities. It's not like that's lost in there. But the colonial powers conceived themselves and their work in the exact same manner. And so it's just, again, something we always want to stay aware of. And then there's the central paradox, is that inequality is both a suffering to be remedied or redressed, and it's also a professional opportunity for us, you know, to go study diseases that we can't study in America, for example, that are still rife in other countries. And then so Jane Philpott has written about mixed motives for students and faculty, and she says ones she'd rather suppress are ones that I actually wouldn't. I think global health, the excitement, the joy, the passion, that's a driver of doing good. But if it becomes, you know, you're just doing a cool vacation thing and you're going to go see wildlife in Africa and then you'll see some other wildlife in the hospitals. You know, if it takes a sort of disturbing turn of that kind and a vacation elective, something like that, that's something we might want to think about critically. And then ones she can tolerate, sense of reward, feeling useful, helping people in need, yearning for purpose. Some people want to go back to, you know, where their parents came from and learn more about it. Obviously, laudable and understandable goals. And then, you know, recognize you're part of a global community. What does that really mean if you're talking about partnerships? You know, thinking of it in an egalitarian way, with our partners having plenty to teach us, having humility, repaying debts, exchanging ideas, obviously, because I always go in thinking I'm going to probably learn more than I teach, frankly, and learn even in a, you know, a very rigorous manner where I would come back and change ethics theory. That is, as I've written in other publications, a white Anglo-Saxon Protestant ethos. And you just compare them side to side, and it's just, so it doesn't even apply to different ethnic groups in America, much less in other countries. And other countries are better at communitarian ways of thinking ethically and can bring to bear much more interesting things in ethics, and you can change the ethics theory. So again, precisely because global health does emerge from a history of colonialism and imperialism of the sorts that I've been speaking to, we need to be mindful of that legacy in our ongoing work. And of course, good intentions and compassionate action are not immune to the power imbalances and inequities that they seek to redress. Brain drain is simultaneously a phenomenon we help create and a disparity we seek to remedy. So, for example, in a project I was doing with UCSF, we were working in Tanzania, and our director was from Ethiopia, and he now was full-time in the US, and we had a Sudanese Oxford Ph.D. who now was working on our team. Now, obviously those could be pluses, you know, contributing their cultural expertise in the areas in which we'd be working, sub-Saharan Africa, but it's still there's a lot of brain drain. So we've taken those people out of the workforce. And one was a bench scientist. And you know, there's not the infrastructure in Africa necessarily for her to do the kind of bench science she was doing at Oxford. So there wasn't a good reason for her to go back, or there was a disincentive. So that's another inequity that we multiply in our work. And envisioning, you know, lower income patients, lower income country patients as suffering persons in need of treatment, as I've said, and then bodies of knowledge who can yield scientific information. And also radical inequality and geographic distance leaves us again haunted by post-colonial power differentials that we're constantly going to be struggling against. So an example is American HIV researchers in sub-Saharan Africa. And I don't do HIV research, but I know a lot of people in here do, so hopefully they'll have intriguing examples of their own or contesting ideas of their own. But the opportunity to study the virus as it evolved in relation to the exposure to drugs was a lost research topic or opportunity in the US, which Africa now offered to us. But of course you're taking a lot of blood and you're doing invasive procedures to learn this, and you know, it's using and exploiting people in a way that isn't exactly what we intend, or could be perceived that way, or too much in that direction. We're not really serving people. And then the resources and prestige that come with international partnership actually exacerbate inequalities within host nations because it disenfranchises those very rural universities nowhere near the big cities that we can't get to and help. And so all the American partners, and really it's very disturbing when you're overseas, and I'm sure everyone here has seen this, but for example in Tanzania, I mean, you would just drive around, even our campus was Muhimbili, it's called MUHAS, and you would see there'd be a sign, a prominent Harvard sign, and then Tufts. I was proud to say UCSF did not post a sign that I ever saw, but you know, you would see like plantings of ownership, and it did look awfully colonialist, and this was just one campus. But, and again, that's a university that's in Dar, so it's much more readily accessible, and who's helping the rural patients and partners that we could have. Also, they have to manage large scientific grants on behalf of global health partnerships with insufficient reimbursement for administrative costs. And if you just look at one statistic, Hopkins from NIH gets 64%, and the foreign university where virtually all the work is done, or most of the work is done, gets 8%. The low reimbursement rate is not enough for foreign universities to build the infrastructure they need to support those initiatives. And so as the project numbers balloon, with all the Harvard, Tufts, everyone else claiming their piece of the pie, the local fiscal agents suffer a financial meltdown, or can. So due to steep disparities in overhead reimbursement and underlying economic inequalities, the reality of partnership is that the African institution is asked to administer a grant that's larger than its entire university budget. And then afterwards the girl was reflecting, and she said, well, all I had to do was protect the perineum and all this, and I thought, you do not even know what a perineum is. You've heard that word and you're repeating it, and incredibly disturbing ethical issues that come up. And I know all of our students who go over, they're offered, you know, here, put this needle in someone's eye. Ooh, you want to try surgery? And this is medical students, but ours go between the summer of their first and second year, and then they'll go as M4s, fourth years. That's the only time they have. I know Duke has a different system. But a huge problem. So we literally train them. We give them scripts. Here's how you should respond to this. Here's how you could consider responding. Here's another way you could help that's more appropriate. Why don't you clean up from the first patient and let the midwife deliver the second baby, rather than feeling you're on a rescue mission, running over and helping someone give birth when you have no idea what you're doing. So. And some examples, and this is the one I was thinking of when I said, I say cultural incompetency, but this is an example of plain old incompetency in my mind. These were students that were fourth year dental, medical, pharmacy, and nursing students. I won't name the university medical school, but I was working for them at the time. I was not even supposed to be involved with these students, but they came over, and the student who was a 4th year at the dental school had just boarded the plane for his long journey with a flagrant, well-advanced case of pneumonia. He also had come inexplicably to me, having traveled a lot, and even at age 19, it wouldn't have occurred to me to go to another country with no money at all. I just can't even conceive of that. And you know, no health insurance, which is easy coverage to get when you're doing projects like this. I'm sure Duke offers something. My university offers very cheap health insurance. So came off the plane incredibly ill and had to go straight to hospital. Our co-PIs, the African way of hosting and kindly, loving, generously supporting, he was giving him food and money, paying for his, you know, it was very embarrassing, you know, that the students had come so ill prepared. So that's, like I say, more flagrant incompetency, and this one might also be, but another different university working in the Philippines, doing a global health experience, they thought it would be cool, and it does sound cool, to go fishing with the local fishermen at some point. But it never occurred to them to ask, hey, do you know how to swim, or are we going really far away from land? And something happened and the boat was unworkable and they couldn't see land and the fishermen couldn't swim, who might have known where to go anyway. So the student just dived in the water and started swimming in some direction. He did survive to tell the tale. But again, just another example. And then more what I was thinking of, insecticide-treated bed nets. You know, we give things to people in other countries and we don't explain the use. We're not culturally competent in the way, you know, anthropologists have tons of examples of things you give. And this one, Food for the Poor, told me they had given fishing boats because they were having communities develop tilapia ponds, fish ponds, as a way to make money and be having a sustainable global health initiative, which was fantastic. But when they gave the fishing boat, they wouldn't know, it was overtaken by the drug lords, commandeered it, and just had this awesome boat to use for their drug trade. So you know, you have to imagine different ways or ask different ways that things could go awry. So, so again, this is from Child Family Health International, very established. They have like 25 countries they send people to, and so this idea of medical electives as medical tourism and honing rudimentary skills on impoverished, needy patients who have no choice, and you know, look at you as if you're a physician when you're just a medical student, or they think, and they'll see you as Western doctor, you know, and that, luckily in the film that I was referencing, the Canadian medical students who made the film just did it beautifully, and there were a lot of people who cared very much and thought very much about the ethical issues. So it wasn't as if the students weren't thinking about it either. Also reinforces harmful stereotypes about us from the developing world, because you may be the only person in this region they ever meet or see, and for the rest of time that will be the story they tell. So if we do something crazy while we're there, you know, that's how people in the West behave. And so obviously it's unethical to expect indigent patients any more than we would ever dream of doing here in another country to take on the burdens of being cared for by us in ways that we're not prepared to offer. So of course we want to consider carefully our presence, and that was the point I was making. They're less mobile and more isolated, so they'll remember the antics forever and keep telling the story of the guy that swam from the fishing boat, you know, and that's sort of how they think about it. And then, so unprofessional conduct, though, in the healthcare setting can create mistrust in and reinforce stereotypes about us, but it can harm the trust between the local community and their local healthcare professionals. You know, why did you unleash these people on us, basically? And so that's something that we would need to think about as well. And so, again, obviously, we would want to learn as much as we can before about the local culture and language. And, you know, all too rarely, people don't do that. We have, where I'm working now, we have experts who will give sub-lectures on certain regions or certain places that people are going, and that's proven very helpful and useful. And then obviously your professors who are the PIs on the projects in those countries will have learned plenty to share. And above all, the people with whom we're partnering, who are teaching us and we are learning from, can tell us. And MOUs, and Memoranda of Understanding, is how you're going to do a partnership will obviously help a lot of this stuff too. So a lot of it can be worked out in advance. Again, I'm not trying to make this sound so difficult, and it's just something to think about and a problem to try and address and solve in advance. Obviously not assuming we know better, but that's hard to do. You know, we come and we're used to our technology, and you know, we think, well, what's taking them so long, or why are they triaging in that way? I mean, when I worked in India doing research, you know, there were like 12 babies laid on a gurney side by side in the neonatal unit. They were in little neonatal, and the decision to put them on a respirator wouldn't even be made. They were excluded elsewhere. You wouldn't even see that. It'd be, you know, their family doesn't have enough money to support such a child, and the physicians there very much told me they felt that it was their duty to prevent the society of India and families from having to bear the burdens of handicap. Now, this was 20 years ago. Things could be quite different on that front, and different people in different regions could say something else. But obviously value differences, and this is common because we're, you know, we Duke students and others, we're just, you know, we ask a lot of questions. That's how we show we're smart and we're interested, and it's a way of honoring people. And it means something different in another culture. Like in Africa, it can mean that you're very selfish and demanding, or you seem very entitled. And even something simple like when I worked in Sweden, in America, when you give a talk, you expect to be peppered with questions, and that means people liked it, and they're engaged. So it doesn't feel bad, but in Sweden, if they come here and give a talk and they're peppered with questions, they feel beaten up and bruised. They've told me. We'll see if Truls has a different Norwegian perspective. But also, when I gave a talk there, and it was just met with dead silence. Oh my Lord. I just was like, oh my God, I have failed. No one's engaged. This is just so horrifying. But they thought they were showing respect by not asking me anything. So even just simple things like that you come across. And yeah, conforming with authority and community norms. I mean, in Tanzania, the students are not expected to ask questions. There's a very rigorous hierarchical relationship between professors and students. And, you know, you just sit quietly, you are a vessel, and the great minds of your professors will, you know, unload what you need to know, and you would just be quiet. That's not what we want from you here, needless to say. But in another culture, you know, you want to think differently about that. And it is a simple golden rule, but it does work. I mean, if you pose to yourself, would I want my family member treated this way? Would I want, you know, a second-year science student delivering my sister's baby, or someone putting a needle in my eye, or assisting with surgery when they've never even learned anything relevant? So, and then of course, respect privacy and confidentiality. Especially with social media, it's very easy to think, you know, you can take pictures of a hospital, or hopefully you would know not patients because of HIPAA, even that you would be used to privacy and confidentiality. And actually, that also differs across cultures. I mean, when I worked, again, in India, and I worked in the genetic counseling unit for part of my research, and it was just a long line of people milling around, hearing each other's very sensitive genetic diagnoses, and it's quite shocking to students from North America, for example, to see how confidentiality is treated very differently there. But still, for us, you know, we would want to think about things like taking pictures, obviously not posting. I mean, that's probably more common sense. And these are just some questions that people can pose to themselves. And there are two to glance. And I didn't mean to mark it all up for you. I do that myself, and I took it out of my own book. So my students at University of Florida College of Medicine, I used to do this thing. I would draw a key for key ideas. And so they named me the professor formerly known as, with the key, like the Prince thing. They're like, why don't you just write key? I'm like, I don't know. It looks like an embryo, they said. So anyway, and this is a very serious problem that most people I know, like I was telling someone else here that I attended a Fulbright Global Health Forum in 2010 in San Francisco. And virtually every person there had had experiences where they had to use their global health money and definitely people here would, in ways that were not what they would have anticipated. So paying bribes to be allowed to be taken by the chief to the people that you need to reach. Very common, things, and people often use their money in that way. And everyone there, we thought, hey, we should write a white paper on this and discuss this issue across our various institutions and the various examples and how we resolve these genuine ethical dilemmas. And but then, intriguingly to me as an ethicist, they said, oh, I've tried to submit that type of publication, or I've tried to add it into my publications on the results of my global health work, and they were told, no, take that out. They were whitewashed by the journals. Now I said, I know journals that'll publish that, ethics journals. We love things like that. So we're still talking about possibly publishing something like that together. But this is just a norm in many places. And this is a friend and colleague of mine from India with whom I collaborate often. And medical education, research, and healthcare are tainted by corrupt practices, selling fake medicines, paying cut money for hospital supplies, bribery of medical professionals, colluding with pharmaceutical companies in drug research, and siphoning public health funds. And an example in my own research, again, this happened to be in India, it was very interesting because people told me with no self-consciousness as part of the research results that they were sharing with me, or strategies that they use in the clinics, to discontinue care for handicapped newborns or terminate pregnancies prenatally diagnosed to be affected with various handicapping conditions. They said that they would tell the parents, the wealthy parents of a wealthy neonate, a newborn, that they needed some very, difficult to attain medical instruments or other equipment when they didn't really need it. And the family, of course, would rush out and get anything that their child needed. And then what they would do with it, they called it, intriguingly also, that they use a British story figure, but they said that's their Robin Hood strategy, is that they're really going to give it to a poor infant whose parents can't afford it, which sounds good. But then they told me they also use it to stock their own resources at the hospital. And that was another level of what they conceived of as a Robin Hood strategy. So just different levels of thinking about corruption and how you might define or not define, or find it justifiable or not. And then a transnational study found that the quality of government, which would be conceived as the inverse of corruption, was positively associated with higher life expectancy, lower mortality rates for children and mothers, and higher levels of subjective feelings of health. And corruption in the healthcare system is one of the culprits for non-fulfillment of the UN's 8 Millennium Development Goals by the target date, as also statistics been reported. And it also exacerbates the harm of natural disasters like the earthquake in Haiti, which makes sense. I mean, all that money is being siphoned off in all these other, for advancing corrupt goals, or not the goals. And again, a case example, and I won't identify the institution for their own protection. But I was shocked, I will confess. I was working on this project, and the chancellor's house was remodeled using Gates global health funding. And they said that it was going to be remodeled so it could be used as a hotel for us, because we went regularly and spent a lot of time in Tanzania. Oh, Tanzania. That part I said no, I just gave some of it away. But anyway, and then it turned out, we didn't. We still paid for hotel bills, and so it was just getting the chancellor's house refurbished and remodeled. And also 2 $65,000 suede interior luxury SUVs were purchased with the money, and presumably to be driving people out into more distant sites, which sounds reasonable. Although I thought, wow, I'd love a car like this someday, and I'll never have one as a professor. But they really weren't even ever driven. They almost were more like a status symbol sitting outside our buildings, and they were, the drivers literally had full-time drivers, and they would just polish the mirrors once in a while, and this is how the Gates global health money was being used. So I remember being quite shocked by that myself. So the ethical questions for the corruption issue and our own co-facilitation of it, if we proceed in those ways, is how can we who do global health in countries affected by corruption generally and in the healthcare system, how can we avoid being morally complicit? How can we avoid exacerbating the negative outcomes of corruption, which, as our Indian colleague already said, he was showing all the ways it's already taking away from healthcare for needy people, and taking away from underserved communities and just going into doctors' pockets or public health officials' pockets. And we're still, how can we avoid both of the above if we use our global health funding to pay bribes or bow to some of these initiatives? And I'm sure people here will have plenty of interesting examples of why they felt compelled, and you do feel compelled, because if you can't get access until you pay the bribe, and you're like, well, I can help 100 people if I pay a bribe to, so you have these ethical calculus that you have to go into. And then the last issue I'm going to talk about just very briefly is inadequate consultation with our partners in low-income countries. And so we have to remember that defining the boundaries of what does and does not count as science is a powerful act in and of itself, and it accords legitimacy to certain kinds of knowledge and practice and excludes others. And as global health rises in scientific prominence and as a funding priority, the ability to define the field and thus what lies outside it is a powerful exercise in inclusion and exclusion. And again, there I would refer you to Joanna Crane's excellent ethnography of the Consortium of Universities for Global Health, where, again, many of you have likely been at these meetings, but to me they seem very, it's a lot of high-powered, prestigious North American universities vying for power and place and a slice of the pie and funding. And there aren't so many of the partners that we say we're working for and with at those meetings, and they're crazy expensive. I mean, even for me as a well-paid medical school professor to afford that meeting, and I don't know how our partners were going to afford it. And so it's these experts and power brokers and prominent researchers from prestigious high-income countries who are having the power to set the agenda for global health, to define it. You guys know the Copland article, Defining Global Health, from 2009, if you've seen that in your classes. And, they are the ones setting the agenda, framing the issues, identifying the problems, and proposing solutions. But there's something wrong with that picture when you're not working with the other side, and that's why I really like Duke's approach of pushing out their Masters of Science in Global Health to be a new one to be based in Kunshan, China, because I think that's an incredible way to you're honoring you're the guests. These are our not only our hosts, but the ones paying for the buildings and co-teaching and co-deciding the agenda of what we should be studying and what's important and how we should study it. I mean, obviously because they have cultural knowledge, we don't, but it's just, we always have to have humility when we go into such settings, and I think that infrastructure, that approach is much more successful and would enable like setting up South-South partnerships. So I really like that, because otherwise it's always a wealthy country flying in and visiting a little bit and then flying away. And even I used to work at Tuskegee University, which many of you will know was the site of the notorious Tuskegee syphilis study violations, and Bill Clinton gave, I think in 1999, like $10 million. And there too, they really have a sense that wealthy researchers come in, do their work, and use them, and then fly away. So just me looking the way I look, I'm the ultimate oppressor, right, in that setting. So I had to do a lot of trust building and a lot of reassuring people, and I didn't take it as a negative thing. I took it as, there's a lot of reason not to trust me or the majority health system I might represent to some, and even African American colleagues from the North who spoke more quickly, spoke in a different way than the Southerners. I mean, you've noticed I speak quickly, I walk quickly. I'm not walking here now, but you would see in the hallways or the hospital, I walk really fast. I like scared people in Africa. I strode up to them, and I just they had books on my back, and they all scattered and ran away. It was so embarrassing in a village. Well, that was when I was young. Now I know better than to stride up with my books. But anyway, so yeah. And then to me, there really have been a paucity of international partners included in the discussion, and I mean this much more broadly, obviously. I again, I personally think Duke does this really well from what I can see. But you know, this guy from Haiti said, how can you talk about collaboration when you're thinking one way and you don't even know how we're thinking? And this is someone who is at the table, someone who is more powerful. So it's just a really good humbling reminder for us of all the things that we need to think about. So the last point going forward, again, I'm not trying to be negative or, you know, say, ooh, it's so dark what we're trying to do in global health, or these ethical issues are insurmountable. Of course not. But I just want us to be vigilant, not only about and humble, about ourselves, about our colleagues, about our students and how we prepare them, and frankly also about our professional disciplines. So again, for me as a bioethicist, by my fundamental training, I have had to recognize and criticize for my colleagues that bioethics it represents a specific cultural ethos that does not serve even everyone in our own society. But this is the bioethics that's been sent around the whole world. And so they're adopting things that don't even fit their own culture and don't make sense to them. And so to me, it's a fascinating and wonderful exercise to go and learn, well, how does this not fit, or what are you doing? Who cares what I'm bringing? I'll just be quiet right now and I'll just listen. What does ethics mean to you? Well, how do you handle these types of problems? And I genuinely believe that that can improve the ethics theory that we use for bioethics generally. And I like to bring back those kind of insights. And obviously, like I've been saying, we want to proactively address and remedy these types of issues as possible in advance. And I use a community-based participatory research approach. If some of you from public health probably know that method, it's, again, treating partners as equal democratic partners in the work that you're doing, whether teaching, research, service, and learning as much as teaching, humbly, and co-implementing their perspectives. And so again, I was highlighting, you know, like we had co-PIs on our Tanzania project, and they really drove the project almost more than we did. So that really was a better way to function, I think. Although it was frustrating at times, because sometimes we thought we knew better or whatever. And just keep learning and growing with passion, because I mean, it is wonderful, and that is the driver of everything we all do. And so, again, I didn't want this to seem unduly dark or judgy by the ethicists. So, thank you guys.